Just wait a minute, Dr. Russell. They're still joining.
I'm talking to the
panelists. Okay, great.
So with Miriam there and Sharon, all I think you represent most of the world here. Is that right? You do represent most of the world. Very good. Now it's live streaming on YouTube. So Annie, you can give that to all your colleagues. Need to
just copy the link. Give me a minute.
Hello, Princey. Yeah. Okay, shall we start?
They're still coming in. I think they're still coming in. Derek, please send a personal a message to Dr. Miriam, please.
Yeah, I'll do that.
Dr. Shabir is there. Dr. Shabir, good morning.
Morning.
Hello, Shabir.
Okay,
Hello.
okay. So Miriam is there, I think. Okay,
Yes,
Miriam.
I'm here.
Dr. Miriam, you can hear us, right?
Yes, I can hear you. Good afternoon in Kenya.
Okay, so we were worried we couldn't see you, so we were worried whether you were there or not there.
Are you able to see me now?
Yeah, you're there.
Very,
yeah.
No,
now
yeah, but it's not very bright. Is there?
Thank you so much.
If you could put on a light towards the front, because the light from behind is quite bright from the windows.
Okay, okay.
So
we can't.
Is that okay now? Or not yet?
No, I think you'll have to switch on the light in front and draw the curtains. Is that possible?
Close the windows behind you.
Good day, Des. Welcome.
Madam Geeta Lakshmi is also there.
All right, so so let's
Is that better?
Yes.
Yeah, very
nice. Better.
Thank you, and I apologize.
No, beautiful curtains you have. You wanted to see that.
Thank you.
And yes, now that we see Miriam is from the Nairobi University in Kenya.
Can someone tell us, we are audible, right? Because there's someone in the chat box who said that voice is not audible, but I'm hoping everyone can hear us.
No, we can. I think all
okay, Dr. Shabir says it's clear, so no problem.
Okay. All right, let's start. Very good. Welcome to all of you from around the world. Russell D'Souza, Professor Russell D'Souza from Melbourne, Australia. I am the head of the Department of Education of the Unesco Chair in Bioethics, and I'm delighted today to welcome all of you and to welcome a very distinguished panel we have that virtually represent the world, right from Canada down to United States, UK, Australia, Israel, the Middle East, India, Hong Kong, and Kenya and Africa. We are demonstrating solidarity, and I'll talk a little bit more about the Universal Declaration and that important role that all of us are playing. So very big welcome to all of you. Today, as you know, is the 18th of the series of webinars that the UNESCO Chair in Bioethics, has been organizing under the in the wake of it. It was under a program called Medical Ethics in the wake of the COVID pandemic, and we have traversed from different areas and covered all the important the workforce that have been involved with this pandemic. And what we continue to see, that every one of us here from the different parts of the world that we come from, all seem are having the same, dealing with the same issue. And we realize at one time this pandemic has brought all of us in it together. Rich or poor, developed or developing, all are having the same issue. And this series of webinars have brought forth this very important aspect. And one other important aspect that came out is that there are so many different aspects are there, but there are different healthcare professionals who are contributing immensely to this pandemic. And it's our endeavor to bring this and make to recognize the contributions and the ethical dilemmas that all have been facing in dealing with this pandemic. So today we are going to today we start, and this will go over two webinars till next Sunday, and it's going to focus on nurses, bioethics, and the response to COVID-19 pandemic the world over. And that's what we'll be discussing, some of the aspects that are going to are everyone's facing, and we're going to see how it looks, how each one is going to be, what they face, and how similar we are, and how sometimes things may be different in some places. And so this will be an important aspect here. And hopefully at the end of all this, like we did with the pharmacy and with the family therapy and so forth, we hope that we will bring this dialogue, this conversation between senior nursing leaders from around the world together through the UNESCO Chair in Bioethics. And this might be the conduit to start a conversation to bring some guidelines, which we are doing in some of the other healthcare professions. So that's our plan, that's our hope, and we'll be seeing how we go through this. Now it's a great pleasure for me to introduce and to invite Professor Mary Matthew, my co-chair here, who's going to be the moderator to speak to you.
Thank you, Dr. Russell, and good morning, good evening, good afternoon. Lovely to see all of you again. Some of you have joined our old webinars, and this is a continuing series on COVID-19 pandemic and the healthcare workforce. We had covered a lot of topics regarding healthcare workforce, but we realized that the person actually in the front line are the nurses. And I think it's high time that we discuss the problems that are faced by the nursing faculty and bring it to the forefront, because every time you hear news about COVID-19 pandemic, you're only hearing about doctors. And I don't think that is the whole truth. And it's about time that the nursing faculty also should come in the forefront and take take part in all policy making also, because many times they are ignored and sidelined. And this is the platform for us to give you the voice to be seen and to take matters of nursing interest forward. So I thank all of you. We have about 9 countries which are represented here. I thank you all. I also have a personal interest because I want to tell you that my mother is a nurse and she's a product of CMC Vellore. So I can feel for all of you. And as the daughter of a nurse, I know how it is to be. My mother is the main force in our house, and I'm sure most of all of you are also. Okay, so I thank you all once again for coming in and joining. Lovely to see that we have, we can discuss problems. This is a platform for us. We may not have the solutions, but just discussing the problem itself is the first step. So I thank you all for coming. And on behalf of the Department of Education and the Indian Program of the UNESCO Chair in Bioethics, I welcome all of you. Dr. Derek is going to moderate the chat box. If you have any questions, please put it on the chat box. And I will hand it over to Dr. Derek. And Dr. Russell, you may like to introduce all our panelists today after Dr. Derek.
Yes, I just finished.
Yeah, Derek finishes. Thank you.
Yes, welcome everyone. I'll not take too much time. Just a request to all the participants to kindly mute your microphones as well as stop your video, because that gives us better transmission and enables everyone else to hear each other clearly. You can put your questions in the chat box that is there at the side, and we will try and answer them throughout the source of this webinar today and the following week as well. And some of our panelists will not be actively speaking today as we had planned. So I also encourage you can view the chat box, and in case you feel you can add to any of the questions or suggestions there, then that will help us, because there may be some questions somebody's asking about a particular aspect of the nursing profession which you may like to add. So you can do that as well. And of course, we'll pick up the questions and we'll try and answer them towards the end of the webinar. So welcome once again, and thank you. Over to you, Dr. Russell.
All right, so
I'm sorry, I just forgot one more. We have this meeting live streamed on YouTube. I'm putting the link as well in the chat box. So in case someone is not able to join or they have troubles with the audio, you can just send the link to them on WhatsApp and maybe even to your nursing colleagues who haven't yet registered, and they can watch the meeting directly from wherever they are. Thank you. Dr. Russell, please.
All right, so here we are. Thank you, Derek. Thank you, Mary. Thank you. Very quickly, I don't want to take too much time because we've got a lot to do. And so this is our 18th webinar on this in the series, which will go on to the 19th. And this is about nurses, bioethics, and the response to COVID pandemic globally. Briefly, for those of you who don't know, the UNESCO Chair in Bioethics has around 250 centers, units in many teaching and other institutions, in 58 countries across all the continents, right? So I head the Department of Education, which covers all the international division, the international program. Now, this program, as you see, has started. We started somewhere in March, April, I think, and this goes on with bringing out, focusing on important areas and keeping the ethics part of it to the forefront. We have a committee, an international committee. I just want to quickly acknowledge a committee that's been there with us. So we have Professor Joe Thornton from University of Florida, Gerard Fortwinkle from Hanover University, Dr. Animesh Jain from India, Baroness Elora Finlay from the UK, Dr. Professor Alvin Chen from Hong Kong, Professor Stacey Gallen from the USA, Professor J.S. Bamra from UK, and we've Alice Lakati from Kenya, and I have Professor Desmond Cahill from Melbourne from the unit, and he will be doing the executive summary, which will be put up along with the recordings. Every webinar has been recorded, and we have an executive summary which Des Cahill from RMIT University in Melbourne does. So with that, I want now we have this very distinguished panel, and we have a number of you. So I'm going. All of the panelists are senior leaders from the various parts of the world. They're very distinguished in their own right. I'll start with Professor Dr. Annie Grace Kalamati. She is the registrar of the Tamil Nadu Nurses and Midwife Council in India, but she also is the head of the National Nursing Bioethics Program of the Unesco Chair in Bioethics. And she is the convener, and the co-convener is Dr. Kristen Jones Bonafitlo from Canada, who's actually from Lakehead University, and she's also a unit head in the heads one of the units of the UNESCO Chair in Bioethics from Canada. And then we have Dr. Selva Titus from the, she's the Dean of the College of Nursing from the Gulf Medical University in the United Arab Emirates. And I'll come across to Dr. Kathleen Digani Condon from New York, from United States, New York. She's a nurse practitioner in the Division of Palliative Medicine and Bioethics from the NYU Winthrop Mineola Hospital in New York. And then we come across from Melbourne in Australia, where we have Annabelle Brown. She's a clinical nurse facilitator at the Holmes Glen in Melbourne. We'll then go to Miss Rhea Gurevich Gal. She joins us from Israel. And of course, she's the healthcare simulation specialist. She's a nurse in the emergency room in the Soroka University Medical Center in Beersheba. Now, it's important to recognize here that the UNESCO Chair in Bioethics is based at the University of Haifa, again in Israel. So the chair is based and situated in Israel. And we'll now introduce Dr. Judy Erlipan, who is a professor at the College of Nursing from the Sultan Qaboos University in Muscat. But I know her, she was working, she was a dean with one of our units, a very important unit of the UNESCO chair before she went to this role. And Miss Vivian Cooper from Wales. This is Dr. Professor Baroness Finlay had nominated and has spoken very highly of Vivian Cooper, who's with the palliative. She's the head of nursing in the cancer hospital in Wales, in Cardiff. And then Karen Caceres, who's, I'm not sure if she has joined us, but she used to be here. She's from she's the Enhanced Psychogeriatric Resource Consultant at the Geriatric Outreach Team in Woodstock Hospital in Ontario in Canada. And I'm then delighted also to introduce to you Dr. Miriam Wagaru, who's the director from Kenya, who's the director of the School of Nursing at the Nairobi University in Nairobi in Kenya. And then I am delighted now to introduce Dr. Joyce Newman. She is the program director and she's a manager, but advanced practice. She's an ethicist, and in the section of the integrated ethics, again in the Anderson Cancer Center in Houston, in Texas. And then, of course, we have Joy Kezia, who's the chief from India. She's the chief of nursing in the Fortis Muller Hospital in Chennai, India. And finally, I'm delighted to introduce to you Sharon Leung, who's the head of nursing education in the Hong Kong Baptist University in Hong Kong, China. So I am delighted that we have this very distinguished panel of nurses who are doing a great job in the front line all over the world. I usually start to say that this very few novel emerging infectious diseases have posed such vital challenges so quickly and dramatically as the novel coronavirus has done. Of course, and on top of that, we are experiencing a worldwide breakup of structures that would normally provide security at many levels for each individual in his or her daily life, indeed for the society and the worldwide. But we now don't have that. But it is at this time, it is important to uphold our fundamental ethical principles wherever possible. And we also experience that guidelines, which are so familiar and self-evident to all of us. Sometimes, as in this pandemic, these also have limits. And so I bring that forward. As I said, today it's that's the team. As the number of confirmed COVID cases accelerates, nurses on the front line of healthcare respond globally have found themselves in unprecedented positions. Today, nurses are making high-stake decisions for patients and their own personal lives. Nurses' roles are now more important than ever. Nurses are often the last thread of compassion for patients. They're the ones doing the screening, taking care of the critically ill, implementing triage protocols, communicating to families, and even attending to the dying. Friends, the COVID-19 pandemic has highlighted many of the difficult ethical issues that nursing professionals confront in caring for patients and families. The decisions that nursing professionals on the front line are fraught with uncertainty, as all the stakeholders in this current pandemic are facing. I just will end with just bringing forth one important Article 13 of the Universal Declaration on Bioethics and Human Rights looks at solidarity and cooperation. We keep this in every webinar to bring forth to all of you, all our panelists as well as our participants from around the world, that solidarity, this is what solidarity is. We are together trying to find answers, trying to bring solutions, trying to bring guidelines. Solidarity as a moral value. Human beings share identity as members of the same collectivity and therefore feel a mutual sense of belonging and responsibility. So then solidarity in this sense is a humanitarian solidarity. It is the expression of an ethics of commitment, a sense of responsibility towards the most vulnerable in society, and not in self-interest, but rather than the interest of others, motivates this cooperation that sees these wonderful, distinguished panelists from all over the globe meet us, join in this moment, demonstrating solidarity and cooperation as we all traverse and face this pandemic together, and hopefully we will all come out of it well together. Now, I will stop here, and I'm going to, before Professor Mary Matthew takes over, we're going to ask Dr. Annie Grace as the convener to say a few words, setting the scene, and also Dr. Kristen Jones Bonifiglo, who's the co-convener, will just say a few words, and then we will set off on this wonderful journey of starting from today and traversing the next week. Over to you, Dr. Annie Grace. Well, you will unmute you. You need to unmute. Can you unmute yourself? I'm trying to unmute.
Her video also is not on, Dr. Russell.
No, video is there.
I can't see. Yeah. I think both of you are trying to unmute.
Annie, can you unmute it? Sure. What's happened?
You'll have to ask.
I think there's a problem at. Yeah. Okay.
Yeah,
Okay. You're
okay.
good.
You're good.
Okay.
Go.
All right. Yeah, good morning, good afternoon, and good evening to one and all. I'm very delighted to be the convener of this nursing bioethics website.
I think there's some. Can you hear me?
I think she's
Yeah,
must
maybe
be
there's
unstable. I think.
And together we are facing extraordinary challenges. As you all know, the virus COVID-19 has turned the world upside down. The pandemic is a new experience for many of us, and we face mounting number of cases, raising death tolls and increasing suffering. 2020 is the year of the nurse midwife, and we are reminded that it was Florence Nightingale, the founder of modern day nursing, who popularized the 6-foot rule for infection control. In many ways, the work of nurses are doing right now, isn't it really any difference the past what Florence Nightingale did in Crimean War in 1858? By now, many people are aware of the role of nurses play on the front line of the pandemic. COVID-19 has also fundamentally changed the way we work with all the PPE, wearing PPE and providing the nursing care to our patients. Restricted visiting hours, restricted family members, denied being the family members being with their beloved ones even at the end of their life. And nurses are assuming the new role of telehealth to provide a virtual settings, how to meet out the patient's psychological need, and all that the nurses are really facing as an ethical challenge in this nature. And thinking of ethical issues, I remember of 3 things, which is mainly the safety of nurses, patients, colleagues, and families, the allocation of scarce resources, and the changing nature of nurses' relationship with patients and families. In the battle against COVID-19, the safety of nurses and other healthcare workers on the front line is a pressing ethical concern, as this has been really a threat to their personal health and well-being, and overall it affects their health. And also we cannot underestimate what is the nurses undergoing. And we need to address these issues like in a way of moral, psychological distress and post-traumatic stress disorders we need to remember. In addition to the assessing of the patient and giving care, as I said earlier, they are all really facing the great threat of their life. And as you know, nurses have a long history of trust with their patients. However, many ethical issues have altered the nurse-patient and family relationship in the context of COVID-19. During the COVID-19 pandemic, many people are dying in isolation from their loved ones, and end-of-life conversations are taking place over the telephone and behind the dehumanizing veil of plastic gowns and respirator masks. The challenge for nurses is to temper these potentially dehumanizing scenarios with imaginative solutions that do not sacrifice compassion and equal respect of the altars of safety and efficiency. So the need for nursing is universal, whatever we speak of. I'm really happy that Dr. Russell could arrange globally the nurses being united here to share our best views. As Florence Nightingale, she always believed in statistics and recording, and this forum should bring us together as a bioethist, and we need to form a guidelines under the leadership of Dr. Russell and bring it a big change in our profession. Thank you.
Thank you very much. Where is Kristen? Can you want to unmute? I just want to acknowledge Dr. Princey Paletti from committee, and also Dr. Geeta Lakshmi, the Vice Chancellor, who initiated the nursing program, nursing ethics program. I want to acknowledge them. Kristen, go ahead.
Thank you.
Kristen,
Thank you, Dr.
yeah,
Thank you,
go ahead.
Dr. Russell. I'd like to thank you personally and also to your wonderful team for your commitment to ensuring that all voices are heard during the COVID-19 pandemic. I've had the pleasure of attending many of these excellent webinars, and I certainly value the opportunity to share knowledge with each other globally, to identify our ideas and our concerns. I'm in Thunder Bay, Ontario, Canada, and my home has many small towns and rural and remote communities here in the north, and we have unique issues related to responding to a pandemic. So I hope today that we'll explore issues from a nursing perspective for both rural and urban communities. And I believe that nurses have always been leaders and problem solvers, able to respond to the needs that we recognize in frontline practice. And I look forward to our discussions today and in the Sunday to come. And I welcome all panelists and audience members. Thank you.
Thank you. And now we'll ask Dr. I'll hand it over to Professor Mary Matthew, who will be the moderator. She has been moderating many different webinars. And so now over to you, Mary.
Thank you, Dr. Russell. And this webinar, like I said, is close to my heart. So what I'd like to say is this is going to run over to the participants and to the panelists. We're going to have this over 2 weeks. That is the Sunday and the next Sunday. We'll continue the discussions. Now, I don't want to leave anybody out, so I'm not going to divide it into 2 sessions. This session, what I will do is give everyone an opportunity to tell us about the ethical challenges that nurses are facing in their respective places and their countries. And from there, we will take it forward. And we should discuss regarding, I hope that at the end of this, we'll have some sort of guidelines and a white paper regarding the ethical guidelines and issues for nurses, because that is very important. So thank you, Dr. Annie and Dr. Kristen, for introducing the topic. And I would like to start with Dr. Miriam. And Dr. Miriam is from Kenya. And thank you, madam, for joining us. She's the director of School of Nursing. And you can unmute yourself. And Dr. Miriam, would you like to tell us what is happening in Kenya and what are the ethical challenges that the nurses are facing there in probably the whole of Africa? Dr. Miriam, you'll have to unmute yourself. I think Dr. Russell or yes, you're unmuted. Thank you.
No, I think we both are, okay, yeah, that's it.
Both of you are, yeah.
Okay. Thank you very much. Good morning, good afternoon, good evening to all of you and to the attendees. Kindly allow me to appreciate the efforts of Professor Russell, Professor Mary, and the rest of the organizers of this webinar, because it's important that the nurses' voices are heard. So thank you very much. So coming back to issues of ethics across in Kenya, there are many issues that we can see. The first thing that we need to say is that we know that nurses, the primary goal of nursing, and as indicated in the codes of ethics, that nursing is founded on caring. And therefore, the primary duty of the nurse is to care for the client, whether individual, family, and community. And therefore, nursing really is characterized by compassion and commitment. Now, since the pandemic started, there are various issues that challenge the ethics of care. For example, there is the issue of beneficence versus fear. The nurses would like to provide care that benefits the patient. that provide for the safety of that patient, that provides for the dignity of the patient, that the patient feels that they can be able to make their decisions. So that is autonomy. But sometimes the highly contagious nature of this condition, with very uncertain epidemiology and no specific treatment in sight, causes fear among the nurses. In Kenya, for example, the first case was announced in 13th of March this year, and it resulted in very rapid expansion and creation of isolation centers where they did not exist. Luckily, Kenya was already preparing for Ebola. So there are areas where there were isolation centers which were being prepared for Ebola. But there are many areas where isolation units had to be created. And therefore, it means that nurses were quickly put into the areas to start working with these patients without very good preparation. They feared for their health. They also had issue of social support. You know, in nursing, we need to develop a very close interpersonal relationship with the patient. But then in this COVID-19, that relationship is somehow curtailed because there is a maximum number of hours that you should stay with the patient to avoid exposure. Also, the gears, the PPEs that the nurses have to put on, in as much as they are protecting the nurses, but they are, one, very inefficient. Two, if you want to conduct a procedure like you want to listen to the fetal heart, the PPEs are limiting. So in the safety of the patient and the safety of the nurse, the protective measures also hinders some of the efficiency. So that causes an ethical issue on beneficence and a fear, and also providing the care that is required. The other issue was the nurses had a lot of stigma because the community sees the nurse as the person coming from the hospital who sometimes they think this person is having COVID, as a COVID transmitter. So then there is that fear also being stigmatized. The nurse also, the social aspect, you know, when we have the patients who are very sick, we would really like them to stay with their families, to talk from the family, talk with the families, because there's a specific, unique comfort that comes from the family. That in COVID-19 is not there. So that is another ethical concern. The other ethical concerns, issues of grief and bereavement. We have witnessed cases where the government has put in place a good measure, though, that whoever dies out of COVID is buried within a period of time. But then the relatives and the social support then are not there, because you who has been traumatized, you've lost your person, and you are the person who is supposed to bury this your person that you have lost without the social support in the care of the community, but it traumatizes the person who has lost their relative. So you look at that, and as the nurse, you want to provide care to these relatives, but then how do you provide it in such kind of measures, which are really good to prevent transmission, but at the same time, it's causing a lot of harm to the people around. Then when we come to allocation of resources, then we look at, for example, the issue of ventilators, the issue of services. How do we provide services for every person? In every society, there is some extent of inequality, where the people who are better off, or the higher social class, are likely to get better care than those in the lower social class. And that raises an ethical issue in terms of justice, allocation of resources. The other issue that we have is resources in terms of allowances. We have nurses in Kenya who have been employed on contract because of the agency to have more personnel. So these nurses, they have the same qualifications with the nurses who are on permanent terms. They are expected to provide quality care and come up with the same health outcomes for patients, but their terms of service are different. They are not getting the COVID-19 allowance as the rest of the nurses. And this is likely to discourage them and wonder whether they are supposed to give the same care. Then we have the other issue that is coming up that we heard about it being announced in the last few weeks about having the retired nurses who are the critical care nurses to come back and work in the hospital. The question that is likely to be raised on this is that the nurses who are retired are in the category of those who are at high risk of contracting the condition. Yet we have so many highly trained nurses who have not been absorbed by the government, whom we think if they are taken in, they would be able to provide better care. They are not at higher risk as the people who are old. Of course, we know that we respect them, they are senior citizens, but we know that that senior citizenry comes with some other predispositions like diabetes mellitus, hypertension, and many other comorbidities that make them susceptible. So do we want to take them? Do we want to take the young nurses?
Dr. Miriam, the problems that you're saying are the same when we were discussing issues regarding doctors, because the stigma attached with COVID is there even for doctors, the same for nurses. Now, I'd like to ask whether you had, did you have PPE was provided to all the nurses, or was there a deficiency in PPE? Were nurses given all the PPE that was required?
Okay, thank you very much. If I look at what the nurses say, and from the media, the nurses are complaining about the PPEs. One, that the PPEs are few. And in our national hospitals, they are few, but it's much better than the rural Kenya, where most of the hospitals are to cater for the majority of the population. The other aspect that was coming in was that the PPEs, initially there was a question of safety. Are they safe? Are they not safe? So then the nurse is not assured, even if they're in the PPE, are they PPEs that will serve the purpose of protection, or are they PPEs that will expose them? So that is an issue. But I want quickly to say that the reason why sometimes we see these issues is because of decision making. If I look at the policy documents that have been produced in the recent past to guide the care in COVID-19, you rarely see a nurse being in that policy document. So the nursing division, which talks about policy, the welfare associations, the regulatory bodies, and all other, even nursing education, if you look at the people who are contributing to those policies, the nursing bodies are not represented. Yet we know that nurses...
I totally agree, because the contact time of the nurses is much, much more with a patient than the other healthcare workers. And their voice is actually not heard and included in the government policies. And that is why this platform is there, so that we make at least to show that your voices have to be heard and you have a lot to contribute in terms of decision making. So Dr. Miriam, thank you. I'll come back to you. And I'd like to go to Dr. Selva Titus from UAE. Madam, you're the Dean in Gulf Medical University.
Yes, yes. Once again, I take this opportunity to thank Dr. Russell and Dr. Annie, as well as Dr. Derek and Mary Matthew for having me in this panel. Actually, just being part of this, it also made me learn a lot more about UAE and it is and the way it has done well during this COVID. Though I come from India, I've been here since the pandemic started. So I just want to give a positive side of this country, because looking at various other parts, I would say that UAE is one country which has done quite well in terms of COVID and the approach. You know, having to know that we are closing to 17.8 million were affected and 10.5 million are recovered, and we've got more than close to 7 lakhs deaths. If you look at UAE, the best thing is that in this last few months, it is, of course, 60,000 odd were affected, but 54,000 have recovered, and only 351 deaths have been reported up until today. And that's a marvelous.
That is very good. That is very a good
And actually speaking, WHO has commended them for the good work that is done. Now, why am I highlighting this is that this country is in the Middle East, is the first one to report a positive case in January. Okay. And when March 11th, when WHO declared this is a pandemic, before that, March 8th itself, they took very stringent social isolation. Absolutely, on universities closed, malls closed, every business closed. And you know, UAE is one of the biggest trading and, holiday center. Yes, tourism. But they just stopped everything where the borders were closed. And that is where they have done extremely well. Just permit me to just say a few things about UAE for the benefit of everybody. It's about 7 emirates it has got. It's a small country like which is made into one, right? Dubai, Abu Dhabi, Ajman, Sharjah, Ras Al Khaimah, Fujairah, Umm Quwain. They came together, it makes about a population about 9.8 million. And if you look at, basically, if you look at this government or the private sector, the nursing community, 88.5% of nursing community are expatriates and immigrants. Okay, only 11.5 are Emiratis, and that is just in the recent past that they have promoted having Emiratis coming in. And if you look at in this 88.5, 59.5, when I say 60% are South Asians, and mainly from my country, India. And of course, Bangladesh and Pakistan and so on. And of course, from other GCC countries and also the West who are senior holding position. But what I wanted to say is that the way they looked after the healthcare workers in this scenario has been really appreciative, and the way they have gone about. Just what I would say is one message that I found as a very significant contribution of this approach of this country towards containing this disease is the massive tests that they conduct. About 5 million tests has been conducted, of which only 60,000 has been found to be positive. And what they did was every healthcare worker, in the initial part when they came, every 2 to 3 days they were tested to see if they were showing any positivity, so that they can be given rest and given so that they are away from others. They invested a lot on their budget in terms of almost 256 billion to address this issue. Now, let me just give you one thing. What did the nursing department do? That is something that I'm sure all of us will be interested in. Ministry of Health Nursing Department, which is coming under the Director of Ministry in the Health Department. What they did was, they, in conclusion of everyone together, they closed all the non-vital hospitals, okay, which is not needed, and converted them to COVID hospitals, some of them, and some of them as a very important non-COVID hospital. That is the first thing they did. Secondly, what they did was, the Ministry of Health Nursing Department and all the nursing directors, they got together to make sure that they mobilize nurses. Apart from, so all the primary health centers, clinics, all of them were closed, and they were brought into these areas which are COVID. Now, there is an ethical question. They are not trained. Can they look after? That's, we'll come back to it. I'm sure Dr. Mary will bring this question later.
Yeah.
But then also, as Dr. Miriam said, nurses who are not practicing in the country, who got a license in their own country, but not got into the system today, were called in to take a short-term, appointment, who would work as assistants. So they did team nursing in those areas where a registered qualified nurse had other nurses who are looking after. From my own university, the final year 8th semester students, BSN program, were called in for volunteering, saying that in another 6 months, they're going to be graduate nurses, and they need to be taken as, as part of their, considered as. So that is something they did excellently well. And they, of course, if you ask me, were they not anxious? Of course, they were anxious. Their lack of confidence, shuffling, relocation. Some of them had to work for 14 days, continuously. They were put in hotels, and they were not allowed to go to their homes. And, it's away from their families. But at the end of it, when we look at it, this country has done extremely well in terms of containing the disease. Other thing is huge psychological support support for healthcare workers was brought in. They were honored, news, telenews, newspapers, everywhere. They brought in a platform where these especially nurses were honored for what good they were. And I know that the Highness of the King of Dubai, even talking directly to the nurse who's taking care and portraying that the good work that she's doing, whichever part of the country that she has come from. That is how this country looked at it.
It is a morale booster.
Boost for the nurse to look after. Yes, there were fear. Will they be able to manage? The other thing that the nursing department did was they also have a training and development department in the ministry. This country has invested over 10 years on IT and online teaching module. That came handy for them in the schools, in the departments, in health, everywhere. So they were giving training online and ensuring that they know how to don, how to doff, and then practice over there. Under the supervision, they put these nurses to work on. But if you ask me, yes, there was a lot of ethical questions in terms of where they well trained. Now, if you ask me this question, where we trained, was Florence Nightingale trained to look after Crimean War soldiers? Where we trained to look after flu, Spanish flu when we happened? We all pulled ourselves at a point when it is necessary, and that is how we are. So I just wanted to say that having been in a country and coming from India, looking at it different perspectives, I would say that ethically, yes, they were challenged in these areas, but done extremely well even today. That is my point.
Dr. Selva, amazing, very commendable that a small country could do something like this.
Yes.
This is where the government and policies make a lot of difference.
Yes.
And where budgeting goes towards what is important. And that is really remarkable. I understand the ethical issues of getting in students who are not fully trained, but like we have here for the same thing for our doctors. The final year students supposed to work, not work. Over our discussions during Unesco webinars, certain countries such as USA absolutely refused to send their students in the front line, whereas UK was liberal. So whatever the problem, a country that has not faced such a pandemic taking measures like this is actually quite remarkable. And it's really to be commended. Thank you, Dr. Selva, that it's something positive.
Yes.
When your institution and your country cares for you, you will work.
Yes.
Thank you so much. Okay.
You're welcome.
I'd like to go to Dr. Kathleen. Dr. Kathleen is there from USA. Dr. Kathleen.
No, I think it's
muted. Dr. Kathleen, can you unmute yourself?
Yes. Hello.
Yeah, thank you so much for joining us. And I understand your sphere of work is palliative medicine and ethics. So I'm sure you can tell us a lot what is happening. You're in USA.
Right? I am.
Yeah. Can you, Madam, you have listened to our previous speakers. Can you compare and contrast what is happening in USA?
Certainly. I do think that we have many overlaps here in the United States about concerns around PPE and safety of nurses. I know another concern that has been very significant in the national political conversation here is the widespread use of untested medical therapies, of widely tested medical therapies.
When you say that, what? Just give us an example of what you mean.
So there was widespread use of hydroxychloroquine along with azithromycin, and so I worry about some patient autonomy issues and informed consent under these circumstances. And recognizing how do we balance the desire to provide good medical care when we have.
Can please mute yourself? Yeah, thank you. Go ahead, Madam.
Okay, when we have what are the issues around beneficence and non-maleficence and
yeah, no, Dr. Kathleen, Dr. Kathleen, my question is, policies in USA, are they conflicting regarding healthcare and COVID-19? Are they conflicting voices in the healthcare policies? Is it difficult to follow, or does everyone in the nursing community know exactly what they have to do?
I think here in New York, people were rapidly called into roles to care for patients, many times beyond their scope of usual practice. So I think that has created a challenge. I also think a lot of the dialogue here around nurses as heroes, both here and throughout the world, has really, on the one hand, acknowledged the steps that nurses have taken to care for patients. But I think the praise here can go from a space of admiration to a space of moral imperative, where nurses may be asked to put themselves in harm's way and can ultimately create a complacency on the part of institutions and our broader public about our sense that we're all in this together.
Is there a difference between the way doctors are treated and nurses are treated in terms of safe practice or anything like that?
I haven't found that to be the case.
Okay, was PPE provided to all nurses? I understand in USA it is not uniform. It's not the same in all the states.
I can speak, that I found that I had PPE available to me, but how PPE has been used has been different. Prior to COVID-19, for example, N95 masks were a one use, and then they were discarded.
Yes.
There has been considerably wider berth taken with them. There are different stories that have circulated throughout the United States where there has been one N95 per shift, one N95 per week, and that creates a real set of ethical issues in terms of our commitment to nurses and our commitment to avoid harm for patients, because nurses could certainly be vectors of the virus and unwilling to transmit.
Yeah, I'll come back to you, Manuel. I'll just go on to Wales and Vivian. Is Vivian there? Vivian. Is Vivian there?
She typed in just now, but I can't see her.
Yeah, I'm not seeing
If you can hear us, Vivian, and switch on your video.
Yeah, she's here. Vivian's here. Yeah. Okay.
Yeah, okay. Yeah. Yes, Vivian, please.
I'm here.
Vivian's
Vivian, hi.
Hello.
Yeah, Vivian, Wales, we know when we were talking to doctors from Wales, they said that medical students were recruited and they willingly came in to do their duties. So just a perspective from Wales, what's happening in Wales regarding nursing practice, and what are the ethical issues that you're facing there?
So Wales is a small country with just a population of 3 million, and health is devolved in Wales. So the Welsh government were allowed to make some of their own policies and own decisions, and certainly things like coming out of lockdown have been slower in Wales than they have in some other parts of the UK. So I work in a really small tertiary cancer centre in Wales, and some of the issues that we've been facing are the major one is continuing to treat patients and their cancer whilst trying to manage COVID a small bedded environment where we were making great efforts to remain COVID-free so that we could continue with
But
cancer treatment.
what is the situation of COVID in Wales?
So we had about 17,000 cases so far, and 1,500 deaths.
Okay.
So far. In our hospital at the moment, we are COVID-free from an inpatient point of view, but at one stage we did have a COVID ward, which was not planned, unexpected, and we had to respond very quickly. And so the issues around for nurses, particularly around, you know, from an oncology nursing point of view, you know, compassion, being alongside patients and their families, that changed for us overnight.
Yeah, because that's what we've been talking a lot about, that when a patient is dying, when a patient is very sick, how do we get the family to still continue to show that they really, you know, they care for the family, but the circumstances are such that they cannot. That is a very big issue that's happening. And cancer care, I'm sure it's even more difficult when it comes to cancer care. But
Yeah.
What are the ethical issues? Did you have shortages of PPE? Did you have shortages of nursing faculty, trained nurses? Was there any issue like that?
We didn't have a shortage of PPE. The guidance changed frequently on PPE, though, so that was quite stressful for nurses. You know, sometimes there were daily changes about whether you were full PPE, surgical mask. That was quite challenging.
Yeah.
Student nurses in the last 6 months of their training were actually deployed onto the wards. Yeah,
okay.
They were.
So they were used, yes.
Yeah, we employed medical students and they worked with us as healthcare support workers.
Yeah, because we heard that in Wales that many students willingly came to work, you know, even if it's not in the front line, at least to help in surveys and contact tracing, those kind of, you know.
Yeah, that's my experience.
Yes.
Yeah.
So Wales is doing fairly well in terms of managing the situation.
Yeah, fairly well. We're just coming out of lockdown, though, a bit slower than everywhere else in the UK. So there are concerns about a second wave, of course.
Yes.
And concerns from a nursing point of view about how we manage that second wave. But the biggest thing that I've noticed is a fear, not just at the place that I work, but if I talk to nurses, they're frightened for themselves, frightened for their families. You know, desperately want to continue to work as nurses, but there has been a survey that actually 50% of nurses want to leave the profession.
Yes, I understand there's an attrition rate now, and that is happening even in terms of when it comes to doctors, that people are thinking twice whether to you know, send their children to be healthcare workers. But
that's something we should all be very worried about.
Yeah, may I ask you, was there psychological support for the nursing staff? Were there frequent counselings or, you know, helplines that were set up?
So we were fortunate. We have within the grounds of our hospital, we have a Maggie's Centre, which is a centre for patients diagnosed with cancer to receive complementary therapies and lots of counselling and support. And because that was closed, it was actually open for not just for nurses, for the whole team to actually take time out and to have psychological support, one-to-one in a group, chatting with each other, just to be able to get away from the clinical environment.
Oh, so because that helps, that really helps, you know, when you know that there's someone else who you can talk to. And I understand understand fear of taking back the infection to homes. So
yeah.
We did have nurses here in India who had to stay for 14 days and not move from the hospital, which was emotionally also very draining for them, having to care for the patients as well as having to think about their family life was emotionally draining. But I'm not aware of any support system that was there in India for the nurses or helpline for the nurses. And I think that is something probably Dr. Annie Grace can think about and recommend helplines. If it is there or not there, you can address it, madam, later. Is there any other challenge that Wales had faced regarding nurses other than attrition rate? And because it doesn't look as bad as what we're hearing from the Asian countries.
No, I think we've been fortunate in some ways. I think the challenge for all of us, though, is how we continue with that psychological support in the next wave, or that post-traumatic stress that we need to formally have some ways of managing that and some policies around managing that going forward, because otherwise I think that is something that will impact on the attrition rate and our ability to attract people to our wonderful profession.
Yeah, thank you so much. Thank you. I'd like to go to Dr. Joy Kezia, Dr. from Chennai. Is Joy there?
Yes, I'm here.
Okay, right. Okay, let's get in India and the perspectives, what's happening here in India. I'd like you to address the challenges, ethical challenges, the issue of PPE, the issue of getting in nurses who are not fully trained, to come into the service.
A very good morning, good evening, and good afternoon to the distinguished panelists, and my appreciation to the organizers and to Dr. Annie Grace, Madam, for giving us this platform to discuss. Definitely, the question on PPE, yes, we've had shortages. North, west, east, south, all across our country, we've had shortages. But nursing leaders in the forefront have stood in the gap. We've fought for our team and our families. We've ensured that our nurses have entered the COVID areas only if PPEs were provided to them. Number two, we've also had a bit of challenges in getting the right specification in the PPEs. Let it be N95 masks from various vendors, a PPE overall kits with different GSMs. Not sure because policies were continuously changing. So this was a definitive challenge. Second, that what you asking me about manpower, yes, we did not have nurses who voluntarily came in all the spheres and all the hospitals across India. Certain places, yes, the communications were really strong. They felt like a family. They realized that the entire world depended on nurses. You know, this year being year of the nurse, they definitely understood that this entire year became hospitals are equivalent to only the nurses, because we did not have clinicians and physicians coming forward with an open heart and mind and saying, yes, we're coming. No, we never had that situation. But I must commend my team of nurses in India who have been constantly, like what I've heard the other groups discussing, other panelists discussing, 14 days, and they get a good period of quarantine or rest, or they're able to go back to their homes. Indian scenarios, 80% of our nurses stay in the hostel. So in our country, yes, we had to find different locations to locate our nurses, to lodge our nurses, to keep them on quarantine, to give them paid layoffs, to take care of their nutritional support. And it was a challenge, but we have taken baby steps, but very firm steps in taking care of the team. And psychologically, the nurses have been counseled, and I'm really happy, proud to say that my hospital, the entire Fortis group, we've got about 40 hospitals across India, and we have counseling happening with our nurses. Every week we have Zoom calls, we have competitions, we've got lots of engagement activities just to make sure that we talk to our nurses like this. And
Joy, I'm sorry to interrupt, but is this uniform throughout India that nurses have a helpline and counseling going on, or is it just in Chennai?
No, it's not uniform. It is not uniform, but we have learned from each other, or most of the institutions are picking it up. So it's a positive trend. We do understand that they need to be spoken to, counseled. Sometimes I've realized over this 5-6 months of experience that the family needs a lot of counseling. The nurses are quite happy, even the nurses who turned positive and who've been treated, they are really happy to come back to work. But, their families have been a big hurdle because of the scare, the fear. And, many parents who become old, they think their children will never get married. They don't want their siblings to take up nursing. they do not want anybody else in the family to come forward for nursing. So these are, you know, practical situations that we really have to deal with. And we've spent a lot of time talking to families. We've spent a lot of time talking to their caregivers here in Chennai. And in Chennai, you know, it was complete lockdown, 4 months, 5 months, and the lockdown is now further extended a month. So how would these children, you know, meet their family members, you know, but still they come forward with a very happy heart every day, day on day. They're here, they're staying with us. And the best takeaway through all of this COVID is that I am part of them and they are part of us. And we are a family. We want to take care of them like mom, father, you know, sister, sibling, whatever. So these are real-time challenges we've had, but yes, we've taken the beautiful steps, and Dr. Ani would stand firm to what we say. We have called back. We've opened, you know, ways where our retired nurses are welcome to come back. They can come back and work. Our student nurses have been taken into task in few hospitals that has been practiced. Yes, these have been initial challenges, but now I think they are, you know, they understand COVID is going to be a way of norm. It's going to stay with us almost, you know. So students are really looking at it in a positive angle as of now.
It's really lovely to see, because this is the first panel I'm seeing actually who has something positive to say in this COVID-19 pandemic. And it's amazing that, you know, the nursing faculty can take such a beautiful viewpoint and be coming back to work, you know. And that's really beautiful, because there was, I've seen a video of a nurse who was not, please pardon my, I need to tell the story because that's how emotional that things are here, where a nurse is standing outside KM hospital and the father has brought the little daughter to see the mother because the child has not seen her mother, who's a nurse there for the past 1 week. And you can see the child calling the mother and saying, come, and why aren't you coming? You know, and the mother saying, no, you cannot come, I will see you next week. I think it's really sad that, you know, healthcare workers, especially nurses, have to go through something like this, but still come out in, coming out so positive. And, you know, the spirit of nursing and Florence Nightingale, which I see in all of you, is it's just amazing and so lovely to discuss and talk with all of you. Thank you, Joy, for
I must add one little, a very little positive thought. You know, India has a good number of male nurses standing in the forefront with my COVID patients. And once they're all in their, you know, overall PPEs, the patient doesn't know who's actually taking care of them. Because the patient just gets to see, you know, the little
eyes, whether it's a male or female.
Right. So
no, because when we were making the flyers and we were making the discussions for the nurses, we had addressed it as she. And I did tell Dr. Derek, do you know that there are enough number of male nurses too? So it is not just, you know, ladies, but we also acknowledge the male faculty, male nurses who have
I
contributed.
want to particularly mention them because they have actually encouraged us leaders, because sometimes I talk to them and then I ask them, hey boys, you guys don't even have a hostel to stay, because you know, most hospitals in India do not have a place of, you know, lodging for the boys. Boys stay on their own. They get into small groups, work, you know, stay in the men's working hostel or somewhere really far away from their homes. So how are you taking care of your food, and how are you guys? Like, ma'am, we're really good. We're happy. And some of them turned positive, and I asked them, shall I, like, you know, send you guys back home? They said, no, we're back to work. We're happy. You've taken care of us, like, you know, more than our own families, and we want to give it back. And all of them are back on duty.
Very good. It's so lovely. It's wonderful. It's wonderful to hear this. Thank you, Joy, so much. And I just want to acknowledge Karen Cass able to join. There's some technical issues. So we're acknowledging you, madam, and welcome to the program. I hope the next session you'll be able to come in. Thank you. And with that, I like. Yes, Dr. Russell.
Can Karen hear? She says she can hear you. Can she just see? Karen, can you, if you can hear us, can you acknowledge us? She's having from Canada. She's having some difficulty with her her internet, and she said she's gotten and she can hear you. So, and she said she could speak, so I'm just trying to make sure that we haven't heard from her yet. Karen Kessels from Woodstock in London, Ontario. All right.
Okay. Can I go to Dr. Joyce Newman? Dr. Joyce from USA. Dr. Joyce, you can unmute yourself.
Well, I'm trying to.
There.
Right.
Can you hear me?
Yes.
Thank you, Dr. Joyce.
Yes. Hi. Good morning here in Houston, Texas. No, I think I must say that that we share many of the same issues and problems related to the, when COVID first started, we had kind of a 3-step process in terms of conventional care and treatment. And then we got more into the contingency plans in terms of how we're going to staff, surge staffing, et cetera. And then we got into the crisis mode. Right now in Houston and in Texas and southern US, Florida, for example, we're much into the crisis mode. And as you may know, that the United States has 46 million cases of COVID throughout the country. And there's certainly been hotspots. Dr. Kathleen talked about up in New York, which is where one of the early hotspots were. I think that the main issues for our nursing staff, and some of these were mentioned already, is the protection of self and the duty to our profession. Yes. And how that is affecting nurses in terms of fear that they may have that they'll bring things home. Several of the hotels in our area were providing rooms for staff that were on the front lines and taking care of in the COVID units. I think one of the other speakers, Vivian, perhaps mentioned that, we are also dealing with patients all the time with chronic conditions. And so I practice in a only cancer institution, and quite a large one. And so the patients that we're caring for not only are facing their cancer diagnosis and treatment, but also then facing this infection. And infection has always been a major problem with our cancer patients because of their treatment and their cancer itself and being immunosuppressed. But now we add this on. We've developed, at my institution, we've developed COVID units, and we have 3 units, floors. We're in a major medical center here in Texas Medical Center, and there was discussion, and the leaders from all of our institutions meet regularly, weekly, if not daily, to discuss practices that will help. So there's been that sharing in our institutions, but in our institution, which is cancer institution, quite large, we have 2 units that we set aside and ask for volunteers. We're fortunate so far, we do have a number of staff that have been contracted COVID. So now they are either have returned to work, or there's some of them are still out. There's about 300 nurses 300 employees who are still out on leave. But that's the other issue, is enough to take care of patients. So we are looking at that. The one thing I did want to mention, though, is that for our patients who become severely ill and sick, the ethical issue is related to with limited resources, which again, we're not like in New York or Italy or other places where there's been such limitations in terms of ventilators. But we are really looking at our ICU admissions and in preparing for the surge, but just in general terms, in terms of ethical issues, looking at, well, who are the most appropriate patients that we can really think we can help based upon what they're entering the ICUs for. Because if that surge does come, we'll have to make some really much tougher decisions. So when we look at it, we look at what is going to benefit the most people in terms of ICU, and ventilators, and where's patient autonomy. So we've discussed, we do goals of care meeting much more frequently and much more pronounced, and also looking at advanced care planning in a patient with good prognosis for their cancer treatment and whatever the chronic illness might be. I think we come into play in terms of helping patients, advocate for patients, but also from a shared decision model, almost to a model of, what can we do to the greatest number, what will benefit the patient, and looking at that issue. And I think that's in a critical care situation or an acute hospital situation that has to be taken in. And having those frank discussions with patients and families about, is it appropriate to send your loved one to the ICU and be put on a ventilator?
Yeah, Dr. Joyce, I just wanted to ask you, who takes these decisions? Is it a committee decision, or do you have policies or guidelines in place? Who gets the ventilator, who gets the ICU bed?
We do. So there is a separate team, like a rapid response team, when these issues come forward. If it looks like the patient will be soon going to the ICU, then we will have that, that will call that response team in. It's palliative care. There's a nurse, there's an ethicist that's on that team. So it's a whole team.
Yeah, because the question of moral injury comes in. If a single person has to take a decision who is to get the bed or the ventilator, it becomes very difficult. So this, if there is a policy or guideline in place, that helps a lot. Yes,
it does. The different services who know the patient best and know that disease best will be part of making that decision. But that's very important. The one thing, additional thing I wanted to say is our professional organizations in our country. American Nurses Association has put out some wonderful resources for nurses and related to, helping with resiliency throughout this terrible issue. So this pandemic. So I really look for resources in the American Nurses Association that helps nurses understand the uncertainty of some of this. Our country is going through a lot of political
time. Yes, political
and yeah, which, it's becomes a state by state, almost region by region issue that we have to deal with and prepare for getting supplies, keeping our staff safe, etc.
Yeah, but do you have helplines open for your staff? Do you have helplines?
We do have psychologists that are available and employee assistance programs where nurses can call and discuss. I get called sometimes as a nurse ethicist in my institution about issues, and I've been on staff calls where and talking with nurses in a webinar or not a webinar, but a WebEx call or a Zoom call. So we've tried to make sure we provide those.
Oh, thank you, Dr. Joyce. We'll come back to you. I just need to go to Ms. Raya from Israel. Ms. Raya? Yes,
yeah.
Please unmute her. Yeah, thank you.
Thank you.
Can someone unmute?
Yeah, thank you.
But I think both of you are.
Raya, if you could just unmute yourself.
Unmute yourself.
Okay. Yeah. Can you hear me? Okay.
Thank you for waiting. Thank you, Raya, for waiting. I'm sorry, we have a big panel, so I need to, get everyone in at the same time. I may have cut off some people too. So thank you for waiting.
It's okay. Big and interesting. Okay, so thank you very much. Yeah, we're definitely also handling some same and common problems and issues and challenges in Israel. But definitely from the beginning, the strategy was to find any kind of way to prevent the increase of COVID patients in the country. Currently, we have, since the COVID started, We have 72,500 people that were diagnosed with COVID positive. We have 531 death cases. At this point, we have 96 people that are connected to mechanical ventilations machines, and 340 patients that are in a severe condition. The strategy in the hospitals was to try and divide the patients that come with symptoms that maybe they have the COVID. So immediately the hospitals changed the emergency rooms and find a way to separate the patients that are suspected to have the COVID. In the beginning, we had excellent numbers, which we could proud with. But after 2 months, when there was a closure all over the country, of course, as you know, like most of the countries, kids they start to study online, and most of the organization, the employees were working online. As soon as they start to open the public areas, suddenly we saw an increased number of patients with COVID. And that put us in a big challenge, because we were worried about the fact that what would be the capacity that the hospital will be able to provide care to patients with COVID. We were worried that we'll be floated with patients. And we saw we saw for many reasons. We have cultural reasons, and also people that were for a very long time in a social distance. When all the public areas were open, suddenly the numbers went up. We had like 2,000 cases a day, between 1,500, 2,000 cases a day. The thing is that the organizations and the facilities and the healthcare system try to find ways to provide the best care to the patients. It starts of providing healthcare online. All the telemedia healthcare systems start to provide online care, telephone cares, and video cares treatments to the patients. We started a project. One of our concerns were the elderly people. We started a project. It's across the country, a project that's called Protecting the Mother and Fathers. And we started a project in the long-term cares, try to prevent the COVID in those facilities. We also start to have all the patients that have a COVID, but without a severe symptoms, we start to provide, we call it home hospitalization. So monitoring the patient through the telemedia and trying to provide all the equipment and all the treatment and the support that they need while they're staying at home, and try to...
Raya, just correct me if I'm wrong. This is from the nursing perspective that you're talking about, or is it?
Yes, nursing perspective. Yeah, nursing perspective.
So the nurses are providing these care? All this?
Yes, nurses are the key component of providing home hospitalization care. Okay. So the daily monitor of those patients is done by the nurses. Once, of course, they report to the physicians, and if there is a need, the doctor is involved and maybe give another orders or some other advice. But on a daily basis, the monitoring of those patients is done by the nurses.
Okay.
Also, the telemedicine support mainly occupied by nurses.
Oh, is it? That's what is the health for nursing force in Israel? Is it expatriates? Is it or is it who's involved in the nursing care? Is it mainly people from Israel, or do you have from outside?
All the nurses are Israeli registered nurses that they got their license from the Ministry of Health. Of course, those nurses that provide telemedicine care usually going through some, you know, orientation and learning sessions. We have a very advanced telemedicine system in Israel. So that's definitely, we saw how it's useful during the COVID.
No, because that's very good, because telemedicine is hardly used by doctors. It's not taken to the, you know, to the full advantage in other countries. But it's amazing to hear that nurses are using it during this pandemic to, you know, help patients, and that is a very good idea. And you know, because especially because the social distancing or physical distancing is there. So, and I'm amazed that. Sorry.
Of course, if there was a need, and after monitoring the patient, the nurse, of course, with the advice of the physicians, decide to do a home visit and to see what's going on with the patient, and if there is more, maybe there is a need to send the patient to the hospital. So definitely they will do a home visit, and they will definitely will be protected. We get the PPE equipment. Of course, we were always monitored to use it wisely and not to spread it all over, but definitely we all had the PPE equipment.
But you don't have a shortage of nursing staff?
We always have a shortage of nursing staff, not only during the COVID.
Okay.
It was before, and definitely, but definitely the the nursing students were definitely got more a scope of doing things in the hospital, and they were recruiting students during the COVID.
To do the work.
The team, definitely. One of the things that we also had is that we noticed that in the beginning of the COVID, the hospitals were empty of patients. Like, people were really afraid. They had to come to the hospitals. So one of the things that the government did is that they made a commercial that the hospital is a safe environment, and we're following all the guidelines that are needed to prevent any infection in the hospitals. And we also, the government posted all over in Facebook and TV and newspapers, etc., that if you feel that you are sick, if you are a chronic patient, if you think that your condition become worse, don't hesitate and please admit to the hospital. Okay. So that's one of the strategies, because one of the worries was that the elderly people, that many of them are chronic patients, are hesitating to go to the hospital when they actually have to go to.
Okay.
Admit to the hospital. So that was one of the things. And not only that, we found a way to provide medication to chronic and elder people by volunteers, that everything worked online. The doctors gave a medical prescription to the pharmacy, and volunteers were taking medication to elderly people.
Oh, so that's beautiful.
And prevent, and of course to prevent their.
Yeah, thank you. Ms. Raya, I think you've given us such a different perspective of how to deal with COVID, and how nurses are also involved in telehealth. We will come back to this, because I have 3 more people and we're running short of time. We'll come back to this. Thank you very much.
Okay, thank you.
So can I get in Dr. Judy? Dr. Judy? Dr. Judy? You're still muted.
Judy, yeah, you're okay.
Good evening,
thank
everyone.
you, Judy. Thank you for waiting. I'm sorry, I need to bring everyone in today.
It's fine.
And then we have to do the same thing next week too, but we'd love to hear what's happening there. You are in Muscat, yes. Right? So how is it? Is it the same as what Dr. Selva said in UAE? Is it the same?
It is almost similar to what Dr. Selva Tatus mentioned.
Yes.
Here in this country, we have 41.7% of expatriates working as nurses. So the majority of nurses are expatriates. And so the country is providing free of cost. All the medical services are provided free of cost for all the people in the country.
Including COVID related?
Yes, yes, it is free.
That's
Yes.
really good. Okay.
Yes, the whole country is provided the service is free of cost. Yes.
Okay.
And if you see the fatality rate, it is only 0.5%, and the recovery rate is around 80%, which is really good, and we are progressing.
Amazing.
Well.
Yes.
Yeah, and whoever is getting admitted into the ICU are taken care of fully, and the recovery is also really good. And the thing is, good containment measures are taken by the government. So we have 11 governorates. All the 11 governorates, the containment measures are taken very seriously, and people are following the rules so that the cases are slowly coming down. So that is a good point to say about Oman. And we have COVID blocks and COVID wards completely separated from the other wards.
Separated from the main one.
Yes, and the patients are taken care of. Though the things are good, going on in a good direction, however, there are few challenges which are expressed by nurses, like fear, anxiety.
And how do you deal with that, Judy? How is it dealt with? How do they have helplines like other places?
We have helplines, and we have psychologists who are there to support the nurses, and we have pastoral care for really the nurses who are really who are in need of it.
Oh, that's also there. You have a pastoral care. Right?
Yes, yes, they are really supported.
Yes.
And the government is taking all the measures to take care of the nurses.
Okay.
So that is how I would say that everything is going in a positive direction.
Okay, but do you have nurses who don't want to work, or what do you do when it comes to?
There are nurses who don't want to work. However, those nurses know that in case if they are not willing to work, because we have something called as contract, because we have to work for a contract. So with that, having that in mind, people don't go behind. They just go forward and work for the COVID-19 patients.
Okay, so are they providing everything for you, PPE and everything is provided? That's not a problem.
Yes, the resources are perfectly provided, because this country is completely supported by the government. So everything is provided free of cost. So even PPE, all the resources are available for the nurses.
Wonderful. Do you have something like a hazard pay? In India, doctors are demanding hazard pay.
Yeah, I heard actually in the government services it is provided, but not in the private sectors. Government sectors it is provided. The risk allowance is provided for the nurses working in COVID ICU, but not for the private nurses.
Nurses, all right, thank you. So we are hearing positive both in UAE, and now we are hearing it even in Muscat.
Thank you.
Yes, thank you very much, Dr. Joyce. Dr. Sharon from Hong Kong, from Baptist Hospital. Dr. Sharon. Dr. Annabelle, I can see you. Don't worry, I'll come back to you. You're the last person. Dr. Sharon.
Mary, you got Canada. You've forgotten Canada.
No, but
Kristen is there.
Yeah, Kristen was the opening batsman, wasn't she?
Yeah, but she's
yeah, we started with Kristen.
Yeah, no problem. Kristen, we will get back to you. We can end with Kristen. That's okay. All right. Okay. Dr. Harry from.
Good evening from Hong Kong. It is really my honor to be part of this webinar. I learned a lot from other countries, and in fact, Hong Kong is a very small place, very tiny city, 1.1 square kilometer only, but we have 7.5 million of people.
Okay.
We have been doing very well at the beginning, I should say, because we are so near to mainland Wuhan, so we got hit very early in January.
Yeah. You're how close to China? What's the distance? It's quite close, right?
Yeah.
Yeah, it's quite close. Okay.
Not very close.
Okay, not as close as Taiwan, right? I'm sorry. Yeah. Okay.
But because we have a precious experience in 2003, the SARS experience, so that has been a very good education process for the whole Hong Kong, for everyone in Hong Kong. So we respond very quickly.
Yes.
So in fact, I would just say the government at the beginning respond a little bit slow in a way that we didn't have sufficient PPE at the beginning to start with. Some of the nurses have to go outside to buy masks because there's been a serious shortage at the beginning in January and February. But then quickly, the government helped to source all the masks. And then later on, we have PPE and masks and all that. The most important thing is that I think everyone in Hong Kong cooperated. Even before government announced any policy,
they were ready. They were ready.
Automatically, you know, they protect themselves.
Yes.
So we've been doing very well. Unfortunately, until this month, and all along in the past almost 6 months, we have only 7 deaths.
Oh, okay.
Only 7 deaths.
How many cases did you have? How many cases did you have?
But now it's different. Only this past 2 to 3 weeks, we have the 3rd wave already.
Yeah, you've been talking about 3rd wave because we are still stuck in the 1st wave and waiting for the 2nd, but you're talking about the 3rd wave. What is the 3rd wave that you're talking about, Dr. Sharon?
Yeah, all of a sudden, because government allowed some exemption of the air crews, the pilots and cabin crew, and so those people from outside, from overseas, commute frequently from other country and back to Hong Kong. They should be the one tested and self-quarantined. Unfortunately, they were granted exemption from this. So all of a sudden, they bring all the virus back to our community. And within these 2 to 3 weeks, we have like nearly 2,000 cases. And now the death toll rise up to 34 already. Yesterday, 4 deaths. It broke records. In the past 12 days, we have more than 100 cases every day.
Okay, and I want you, Dr. Sharon, to tell me about the nursing staff. How are they coping, and how are there any issues when it comes to them? Are they well protected?
Nurses are coping very well. I should say we have the first doctor get confirmed yesterday, but he actually got it from family member.
Okay, not from the hospital. Okay.
So we have been practicing this protection very well. We now have sufficient PPE provided in hospital because we have the public healthcare system under the hospital authority. We have about 43 hospitals and institutions. And under that, we have about like 28,000 beds.
Okay.
So about like 90% of doctors and nurses work under hospital authority. And all these people are having sufficient supply of PPE. But for those in the community, the elderly home, the OH home, we have about like 68, below 70 of the elderly home. They are non-government organizations. So they get the funding from a social welfare department. You know, usually the resources much less compared to acute hospitals.
Okay.
So in these past few weeks, we have like a mass outbreak in several elderly homes.
Okay, so that is an issue in a lot of countries.
Yeah,
yes.
So that is a major concern we now have. And we still could not do the mass testing. We don't have sufficient
mass
resources.
testing. Okay.
So
you test only when a patient is symptomatic.
Yes, those have direct contact and all that. And we hope that the mass testing is coming because the mainland government is sending people over to Hong Kong and to help. And we are building temporary hospital in a stadium. And hope to increase some hospital bed, 500 hospital bed, bed in the Asia Expo, already open yesterday.
Okay, no, they're using, because in India also they have started using these stadiums to build these massive COVID hospitals, but unfortunately there are not many takers for it. 50% of the beds are not occupied, and we don't know why that has happened.
Oh, we arranged that. We arranged that under the hospital, the Center for Health Protection is doing all this statistic, contact tracing. They're doing a lot of work. Then that we will screen the patient, those with mild symptoms.
Yeah.
We reallocate to those temporary hospitals.
Yeah, thank you. Is there anything else? I'm sorry. Is there anything else you'd like to share?
The challenge about the nurses training. Unlike other countries that I have heard, in Hong Kong, we suspend all the clinical practicum since January.
Okay.
So at least 20% of our practicum hours were exempted.
Mm-hmm.
But our graduating student allowed to graduate without sufficient experience.
Oh, so they graduated before time?
They cannot, no, they cannot work, they cannot practice during this period.
Okay.
So this is something quite worrying. And I heard that seems quite a number of countries making good use of this opportunity to engage a student, which is something good.
Yeah. Okay. All right. Okay. The policy is different there in Hong Kong. Thank you, Dr. Sharon. And I will go to Annabelle. Annabelle, thank you, from Australia. Patiently waiting. I'm so sorry I have to cut all of you off, and because we have now reached 2 hours of discussion. So you know how you know how it is. Annabelle, can you unmute yourself, please? Yeah. Thank you, Annabelle, for waiting.
All right. Hello, everyone, and thank you so much to Dr. Russell, Professor Mary Matthew, and Dr. Annie Grace for giving me this opportunity to come on this panel. I can only talk from a general view in Australia because depending on each state, every state has their own rules and regulations. Again, depending from acute care to aged care, from private to public, and from regional to metro, it's all very different. Different protocols everywhere. But the main ethical issue here that we face is very much the same as the rest of the world is facing. Fear and anxiety in the nurses, and they're having to work longer hours, the tiredness. Saying that we do have, all the hospitals have an employee assistance program, which was in place much before the COVID. It was always.
This is a nurse assistant? Is it called a nurse assistant?
We have counselors, and it's for everyone, any employee in the hospital.
Okay. All right.
Okay, and that was always in place. It was not something new that was started because of COVID.
Okay.
We could access it anytime. Say we had a patient that died suddenly on us, or something that we had trouble dealing with, we could go and talk to them. It was available free of cost in everything in every hospital.
So you had systems in place, so you're just utilizing what was already there.
So
that's a good thing.
What is there, so that the nurses could go there and talk to them. At this time, they're even allowed to, in some organizations, if they're feeling really overwhelmed and they want to take a few days off just to be with the family or whatever, they're allowed to do it, depending on the discretion of the unit managers.
Okay. Do they get a hazard pay? Do they get an extra pay for working?
No, they don't. No, because they're all on contracted work. So if you're contracted for those hours, you get paid anyway. It just comes out of like compassionate leave or something like that.
Okay. But are nurses protected well there in Australia?
They are protected well, but the dealings they have, because our hospitals now have stopped visitors from coming in. So we have no visitors allowed in the hospital, except on very rare occasions if someone's dying or if they're palliative. So the nurses are having to deal then with irritated relatives, as you know, who can't understand and deal with things. So that's where they come. They have the stressful situations in there.
But aren't there counselors to deal with this situation?
No. No, because when you get the calls in the wards and stuff like that, it's the nurses dealing with it.
Okay, so they're taking care of that aspect also, which is
They
difficult.
take that
In
care,
addition,
yeah.
you
If
need
it's at the entry level, the security can take care of it. But if it's a phone call in the ward, then the nurses have to deal with it.
All right. Okay. So is there Annabelle, tell me, are the nurses being trained to handle the situation?
You learn on the job.
Okay, so there's no training.
But no. Training wise, in the aged care, we are not allowed to have students. The students are not allowed to go into the aged care because, as you know, in Victoria, the aged care is affected quite badly now. Okay. And in Victoria today, from today, actually, we are in stage 4 lockdown, as Dr. Russell would know.
Yeah.
And so therefore, in the aged care, we are not allowed to have students. But the 2nd and 3rd year students can be utilized in the acute care. So they are still allowed to go into the acute care, but not into the aged care.
Yeah, but they
students.
But they do have the confidence because PPE and all everything is provided.
Yes, PPEs are provided. I had students down in aged care way back in March, and even at that time there were PPEs. Saying that again, there was some aged care that did not provide PPEs. But the one that I went to, yes, even the students were taught all the on and off, and even there was no shortage of PPEs to be used at that time. Another thing they face, another thing the nurses are facing is the everyday daily protocols keep changing.
Yeah,
that we've been something they have to get used to. And if you miss a day work, then you come back and it's a whole total different situation.
Yeah.
All right. Staffing wise, in way back in March, the Australian Nursing and Midwifery Federation, they actually they had 142 nurses. They were basically from school nurses, clinical practice nurses, primary care nurses, district nurses, people from the corrections departments, and other nurses that didn't actually practice in the acute care. They ran a crash course, where they had 22 workshops held, both in theory and practice, and they reoriented them to the acute care.
Okay.
All right. So they could utilize those nurses if push came to shove.
Okay.
Those nurses could be brought in because they were taught everything.
Okay. And actually, that's very good. It's a good, they get exposed to, a different aspect now.
Yes. Yeah. And another thing was on the 2nd of April, the federal government also launched a 4.1 million online training program, which was 20,000 registered nurses upskill themselves. So ward nurses were able to upskill themselves to ICU and high dependency units.
That's really good. That's really good that they're concerned about. I'm not just sending them, to handle a situation where they're not confident about. So
and all these courses
is important. Sorry.
Yeah, these courses were free. The ones held in March by the ANF, they were also free because it was all funded by the superannuation companies.
Oh, lovely.
That we have.
Wonderful. Thank you.
By the First State Super, First State Super, Hester, and ANF, they funded that program that ran by the ANMF in Victoria.
But there's also, Annabelle, the government has seen about mental health.
That's what I said. The federal government gave a 4.1 million online courses.
The mental health, because for healthcare staff, including nurses and doctors, special funding now for mental health because of this the effect of COVID. So there's a complete a whole division, and they've actually created a deputy chief medical officer only for men in Canberra for the whole. You have the chief medical officer. They've got the deputy chief only mental health again, and so staff. The frontline, the healthcare workforce, they've put in a lot of money now for mental health for that. So that's I'm glad it's pretty good actually. All this has been there even before, as Annabelle has said. Most of these things have been there well in advance of before COVID came in.
So thank you, all of you. Now, I'm just going to run through. Just give me the statistics of. Do any of you have any statistics regarding the death of the nursing faculty in their country? Are you aware that how many nursing? I'm not talking about doctors. I think Dr. Annie is already smiling, so that means she has something. Dr. Annie, any statistics from India regarding how many nurses were, are not affected? I'm not talking about affected. Have we lost anyone to COVID? You'll have to unmute yourself.
I think Kristen had posted some information as well.
Yeah, let's just hear it. Dr. Derek, let's just hear it from different countries. Dr. Annie, any numbers that you have?
Yeah, there is a survey, and in the journal it was published. In India, there is no proper registry, but however, they say around 54 deaths in the country. And they say, but in Tamil Nadu, we have faced from our government, it is so far 4 deaths we have faced in the government sector. But I'm not sure about the private sector, what is happening. There is no track details about that.
But isn't the Nursing Association taking this up to keep track of how many?
Yeah, now they are all doing that. They said they are going to start up a registry for this, and they are going to work on it. That is what we read it in today's TNI newsletter for this month. So they are going to do that.
Take it up. Okay, right.
Yeah.
Thank you.
And I would also like to add one more thing, like here, when in India, that in Gujarat and Karnataka and Delhi, some of the state, they used the final year nursing students, and they were paying 9,000 rupees as an honorarium with food and accommodation free for the students. And they were also utilized in the part of care, and retired nurse also been invited. Like in Tamil Nadu, if you take, the government of Tamil Nadu have arranged a separate helpline for nurses to give counseling when they feel depressed. They can call that number and they get counseled. So such things have been done in Tamil Nadu also. And we have hired 1,300 nurses for a contract basis in Tamil Nadu, especially for COVID situation, for the COVID management. And the students, they've been just given an open call for the government institution to come and work voluntarily. So some of the students have really responded well, and I could hear from some of the deemed universities. The students have gone back to other states, like from Chennai, one student is from Himachal Pradesh, and he was doing a community screening work. And he has sent us a picture that he has been doing such a work, and he contracted COVID, and he has been recovered. So such cases also there. But here I would like to say that community level going, it's mostly my male nurses are being really going into public health sector. And we should not forget the public health sector. They really do very well in going home to home, every door to door, and doing the screening. And especially the public health staffs are involved in these aspects in India. So they are the real backbone for us here. Though clinically we are talking about all hospital management, and we shouldn't forget the public health side where they are going and screening. And the government has taken some of the volunteers from non-nursing sector also, but the nurses is the key person who are doing this job in India.
So we probably will take this up a little, in the next session, but just a run of how many, and it will be nice for everyone to keep track of what is the numbers in their country regarding how many nurses have been affected and how many have died on duty. Annabelle, anything from Australia? How many nurses? Dr. Annabelle? Anything about if any nurses have died in Australia? Can you unmute yourself?
You are not yet unmuted.
Unmute yourself.
Yeah, now you are.
Any numbers?
I have an update from the 31st of July, where they said there were 723 people there, but they haven't told me how many people have died.
Okay, so how many were infected?
So the infection is about 700 nurses, but there is no deaths as such. I haven't got a total for that, which I can get it on the next one. Yeah.
Okay, right. Thank you. Sharon, anything from Hong Kong? Dr. Sharon, anything from Hong Kong numbers? No? You have to unmute yourself. To unmute yourself. Yeah.
Yes.
No numbers.
No even confirmed case among nurses.
Okay, very good. Thank you. Raya, Ms. Raya, anything from Israel? Numbers, about nurses? Please unmute yourself. Someone please help Dr. Yeah, thank you.
We had only one case of death.
Okay, right.
Nurse.
Nurse, yeah. Thank you very much. Joyce, Dr. Joyce, anything from your side? Any numbers that you can give us? USA?
I will have to, I was just trying to find that on my phone.
Okay.
I know the last number I heard was 500.
500 deaths or infections?
Deaths from COVID, but
okay.
I don't
very
know if
sad.
that's, yes, I don't know if that's includes medical physicians. I will find that number for next week, but
yeah.
there's not real good numbers specific for nursing professions, but we've lost a lot of healthcare, hundreds of healthcare workers.
Yeah, that USA, that's what we've heard. Yeah, right. Thank you so much. Dr. Selva, anything from UAE numbers? Please unmute yourself.
Yeah, no, there's no reported deaths, but there were ill, a couple of them. They were on ventilators, but they all got back into, doing well, I must say that. So there's no death from nurses.
So still good news. Thank you.
Yes, yes.
Okay, Dr. Judy, anything from your side? Numbers?
We have no reported cases of death in Oman, though there were around 54 nurses who were infected, but none of them became seriously ill. Everybody was, they came back to normal and they were quarantined for 14 days and they returned back to their work.
Okay, right. Thank you, Judy. Thank you so much. Dr. Miriam?
Thank you very much.
Dr. Miriam, Dr. Miriam, I've been accused of cutting you off, so my apologies.
Sorry. Thank you. We have had about 363 deaths in Kenya generally, and out of that, we have had 5 nurses who have died.
Oh, okay.
It's difficult to find out whether they contracted the condition in the course of of duty, though.
Okay, right.
But we have had so many also who have been admitted
Infected.
or quarantined for having come in contact or having been exposed.
Okay, right. Thank you. Vivian, Wales? Anything from Wales? Is Vivian there? You'll have to unmute. Yeah.
So the numbers across the UK of nurses who sadly have died, 62, 35 of those are registered nurses and 27 healthcare support workers.
Okay.
And in Wales, we've had 9 deaths, 9 nurses have died. One of those in my team.
All right, okay, thank you. Have I left any country out? Joy, I'm not asking you. Do you have numbers? Do you have any numbers? No, all right. So because I take, yes.
You left Canada. We've not heard anything about Canada.
All right, Canada.
Because
I'm coming
Karen
to
was not there.
Yeah,
Karen was not there. And I know that she.
Correct, but correct. I'm coming to Kristen. She's going to close the show. So, Kristen, I've been accused of leaving you out.
No.
Okay.
Normally it would have been you were co-convening, so Karen we would have got Karen, but Karen has not been able to come in because she's having some difficulty with her internet. She sends apologies. She just sent me. She's on. She can hear us, but she can't.
Kristen, it's all yours. We're ending with you, numbers and something to look forward to our next sessions.
Yeah.
Okay, great. Thank you so much, Dr. Mary. So in terms of healthcare providers' deaths, stats from June show about 16 healthcare providers' deaths. Only one of those individuals was a nurse. Okay. Otherwise, support workers, that type of a thing. In Canada, we have approximately 117,000 confirmed cases with 9,000 deaths, with over 100,000 people recovered. And one of the main issues that I hope we might talk about in the next webinar, and that is certainly a challenge in Canada, is our ability to do testing and the response time in terms of finding out the results of that test. So I'll just give you a quick example. Here in Thunder Bay, at the start of the pandemic, we actually weren't able to do testing. We had to send all our tests out to a large city, Toronto, and it took up to 10 days for those test results to come back. So that certainly impacted decision making. And when healthcare providers were suspected of being exposed, they actually had to quarantine for 2 weeks. And so we had a big staffing issue around that. So I hope that we can talk about that in the perspective of the different countries in the next webinar.
Yeah, we should do that. Thank you so much. Kathleen, I haven't asked you the numbers because USA, we've already got the numbers. So that's why I didn't ask you. So I want to thank all of you. Such a rich discussion and such a beautiful platform to listen to all of you. My apologies if I've been getting the flack from the chat. I can see for cutting all of you off, but my apologies because we have past 2 hours. It's 2 hours, 13 minutes now. We will continue this discussion next week, and thank you all for joining. And with that, I will hand it back to Dr. Russell.
Yeah, thank you, Dr. Mary. Thank you very much. It was certainly, Derek, is there anything you would want to bring in from the chat?
No, not really, because I think the discussion has been quite comprehensive. The general feedback is everyone has appreciated this wonderful platform, and we've had a huge number, over 300, almost touching 350 at times, of nurses, students, and other faculty who have been here. And also the YouTube live link has been very popular. A lot of students have been there and have written their appreciation. I've put the link on the chat, so the recording will be available there as well. So in case you'd like to share this with your colleagues and your students even later, you're free to do that. You can download it from there later. And again, the other issues that have been typed into the chat box just for the benefit of all the attendees and participants, we'll be circulating this during this week to our esteemed panelists, so that the following week, we'll see that we cover all the issues as well. So thank you on behalf of all the attendees and all the participants, to our panelists for sharing, and of course, all the good news that we heard. Selva and Judy and the other participants, it's always good to hear something positive coming out of the pandemic. So thank you for that, and looking forward to next week. Dr. Russell, please.
All right, thank you, all the distinguished panelists. I have to say that I myself have learned a lot, and it's been very interesting. As Annabelle has told you today, we are having, but in the bigger picture, Annabelle, we are having, it is not really, we've gone into, tonight is the curfew from 8 o'clock today. But in actual fact, when I look at what's happening around, we had, we've got about 150 deaths or something like that. And so that's unfortunately there is in Victoria, but there are four other states that are virus free, and that's the ironic. It's only one place that we've got a infection. We've got a crisis in the aged care, and that's the issue. But anyhow, it's been wonderful. But what's the good news is that next week we will be having, we won't be having too much of introductions and so forth. So we will have the whole 120 minutes of going into the deeper. Now we have a picture of what's happening around the world, and you know, I'm sure all of you all will agree that we are all in it together. We're all doing the same thing. We're all having the same issues, isn't it? So solidarity. So we have established solidarity. Next week we'll continue and into the more defined areas that will be more interesting, and from there we'll hope to, as Miriam had brought up, I think if all of you agree, like we're doing with the pharmacy and family therapy, you may like to come up after this with one of you taking the lead to draw up some sort of guidelines and from the proceedings from this. And we also have another, I'll probably get Kristen, we'll be having the summary of this to be published in the Global Bioethical Inquiry, the Index Journal of the International Journal of the Unesco. So we will be looking, and probably all of you as co-authors to that. We've done that for the others too. So we'll have a co-authored. Is that okay, Kristen? Yeah. So we'll be keeping that in mind. Des will give us a summary, then you'll all add to it, and we'll have the a paper that will be published in a cited international journal. Okay. So all the best to all of you. We'll see you again next week. Stay safe, stay well for the coming week. All the very best during your week, and we'll meet you all on Sunday. And we'll take it on from there. Thank you.